All right. Hi, everyone. My name is Asta, and today I'll be presenting on common gynecological infections and treatment. So thank you all for joining. So a little bit about me before we get started is I went to University of Iowa for undergrad and got a bachelor's of science in biomedical sciences. And then I just moved across the river after a year off and started at the Carver College of Medicine at Iowa as well. And I'm currently a third year medical student. So I'm just about done with my core year. And I'll be starting advanced rotations next spring. So very exciting. And for my involvement with Motivate MD, I spent 3 months as an editor, advisor, blog post writer, kind of a jack of all trades, but that's exactly where I like to be. So kind of done a bit of everything. So if you guys could also participate a little too and kind of put in the chat where you're from and what year of education you're at and maybe what you want to learn today. And yes, I will wait until I get at least a couple responses so we can wait if we have to. Awesome, Eve. Thanks for being the first one to share. Anyone else? Just kind of the year you're in school, if anything. Oh, perfect. Charging through secondary apps, very real. I'm so excited to not do that anymore. So I get your pain. Um, Hello, Andrea or Andrea. Hi, guys. Thank you all for contributing. I'm so excited. Glad you're all very excited to learn anything about the topic. I actually don't want to go into OB-GYN. I want to go into peds, but OB-GYN is high on my list. So I just really enjoy the topic and I really enjoyed learning about it when I was on my rotation in preclinical. So I think it's just kind of a nice idea to get an idea of what this kind of stuff looks like since you don't really hear about it until you're in medical school. So, okay, let's get started. Okay, that is, by the way, this is a picture of me after a long, hard day at work on my surgery rotation retracting. And I was like, let me go home, hold my cat, and call my mom because that's kind of how this stuff goes. So just a session outline. We're going to go through a case with an example. We'll go through a physical exam, think about some differentials together. So you do have to participate as well there, kind of go through an assessment and plan and talk about all of the differentials today. So as I said, please actively participate. I don't want to just hear myself the whole hour. Oops. And you can fill out the SOAP note throughout the presentation, and then you can complete the quiz and offer any feedback. And that would be here. So it kind of looks like this. If you don't have it open, I believe it was sent in an email. You can just scan the QR code here. I'll just give like a quick 10 seconds for you to scan the code and open it if you'd like to just kind of follow along and complete a SOAP note with us. It's actually a great practice that you guys are doing this because they didn't really introduce this to us until we were about to start rotations. So if you know this is a huge leg up when you start actually working in the hospital and you're in med school. So really good that you guys are doing this. Okay, so the first thing here is that I'm giving you a 28-year-old female patient, and her chief complaint is that my lower belly hurts. What are some things you want to ask? Where did my chat box go? Yes, when did it start hurting? So how long, how many days has it been? What other questions do we want to ask? Her lower belly pain. Maybe what kind of pain it is? So it's a dull, achy pain. I didn't write this in here, Eve, so good for asking, but it's been going on for maybe 4 days or a couple weeks, actually. It's been going on for a couple weeks, and it's been this dull, achy pain in her lower abdomen. What other symptoms do you want to ask about that can be associated with this? Come on, guys, you got to give me something. Otherwise, we'll all just be staring at each other. Thank you. Does it radiate anywhere? No, it doesn't. It's just lower belly. Couple more questions. How frequent is the pain? It's kind of a constant, dull, achy pain is what she's complaining about. What else besides the pain should we ask about? What are some other localized symptoms we can think of? Anything make it better or worse. So good. I'm just actually going to show you guys the rest because this is at the bottom. But so she's tried an over-the-counter, this is the last bullet point here. She's tried an over-the-counter antifungal suppository called Monistat, if you've ever heard of it. So you can buy this over the counter and women use it for yeast infections, but it did not help. And some of the other things that I was trying to get some thinking about is, so she's had a low grade fever, about 100 with chills. So something systemic. And she's had no vaginal bleeding, but she's had some mild discharge. And she's had some burning with urination, which is called dysuria. She's also had urinary urgency, which is when you need to go now. And she's had frequency, which means she's going more times, she's urinating more times than she would normally in a day. So that's kind of like the picture she's presenting here. Besides today's complaint, is there anything else you should ask about? Kind of leads into my next slide. Well, if this is today's history, then what other history should we want to know about? Has this happened before? No, but that's a good question considering she tried Monistat. Maybe she feels like it's a yeast infection. It has a similar type of presentation to that for her. So she's like, no, it's never lasted this long. Usually, I take a Monistat and it feels better. But what else we want to hear is kind of other past history things. So she has a history of 2 bladder infections in her early 20s, but she's never had any recent UTIs or recurrent ones, which means multiple ones back to back or more often. One thing you always want to ask about when you have that kind of lower belly pain in women of childbearing age is, when was your last menstrual period, or LMP? She says it was 3 weeks ago. It was normal, on schedule for her, regular, no extra bleeding or anything. And she has no known history of any sexually transmitted infections. For her family, her parents are both alive and in good health. She really has no concerning family history. She's on no medications, has no allergies, and no surgical history. Remember, she's 28, so she probably doesn't have a lot of history going on. For her social history, she's a high school teacher. She's single. She lives alone. She does not smoke or use drugs. She drinks a couple glasses of wine a few times a week, maybe like moderate, mild concern for maybe an alcohol use disorder, but nothing really that concerns you or jumps out at you from here. And what's one huge thing that of history related that we want to ask about that we didn't really get in the past couple slides? She's having lower belly pain. She's having vaginal discharge with fever, burning on urination. What is a very important part of the history taking that we've missed here? So one thing that we want to think about is a sexual history. So this patient seems like she's having kind of symptoms near her genital area, considering she's having discharge, she's having burning with urination. There's something going on in that region. So you definitely want to ask about her sexual history. So when you ask, this is really important because this is something you'll learn when you're a medical student, is how to kind of finesse this part of the interview. Because you can talk with the patient all day about an upper respiratory infections. Are you coughing, sneezing, had a fever, but you have to be more careful with how you approach a sexual history because it could be very uncomfortable for them for a plethora of reasons. And you have to show that it's not uncomfortable for you. So one good thing that I like to advise people is, when you're asking for a sexual history, you want to transition into it by letting them know why you're doing it. So one thing that I'd always keep in mind for a couple years from now, when this might be you, is you want to say, hey, so some of the symptoms you're having, it really sounds like um, I'm really concerned that these kinds of symptoms could be related to your sexual history or otherwise. So I just wanted to ask you a few questions about that. Do you have any questions for me before we start? That kind of gives a good intro for them to understand, okay, she's not just asking my sexual history for no reason. She's asking it because it relates to my symptoms, because not everyone makes that connection. And also letting them know that, hey, like if I have any questions, I can ask right now. So that's like a great way to transition into it when you're history taking. Because the way you do it is definitely very important with how comfortable they'll feel with you and sharing every detail. So oh, I didn't mean to go back. All right. So for sexual history, How many partners have you had in the past 6 months? I've had two male partners. When was your last sexual encounter? One, it was 2 weeks ago. Do you use protection? She uses condoms inconsistently with her partners. They participate in vaginal and oral sex. You'll learn that you have to differentiate three different types of sex you could have and be very clear with your patients as they may have different definitions of sex than you do. So if you make it clear what you're asking for, they'll know they should be answering. She's never been pregnant, and dyspareunia. This is a very fancy medical term for do you have pain with sex? And so this is something that we ask women sometimes. It's very non-specific finding, so we can go with like a lot of different kinds of conditions that can happen along the genital tracts. But it is one to consider, definitely. But she's not having any pain with sex. So physical exam. I hope this is not blocking the pictures. Okay, great. So physical exam, her heart rate is 72 beats per minute. Her blood pressure is pretty normal, 115/75. Her respiratory rate is 14. Anything up to 20 really is okay. Her body temperature is 100.6, so she does have a very mild fever. We actually don't consider it a fever until it's 100.4 or above, I believe. And then her oxygen saturation is 98%, so perfectly fine. One thing that I always forget to do so I'll remind you all when you're giving a SOAP presentation, do not forget your vitals. I forgot this morning and it's perfectly fine, but definitely a huge point is your patient in acute distress. Well, she's not. She definitely has something going on, but she's not about to like go into shock on the table. So that's good to know. She has cervical motion tenderness. So this is very indicative of what will end up being the diagnosis. But what cervical motion tenderness is when you do a pelvic exam. So this is what the hands are doing in this image. And they feel up to the cervix right here. And like it's very uncomfortable for people with uteri to have their cervix or to have a pelvic exam in general, but it is very, very uncomfortable for this patient. She has cervical motion tenderness. It really hurts. They kind of jump out of their skin. It's actually called, I believe, a chandelier sign because they kind of jump up and hit the chandelier is I think how it goes because it's so uncomfortable for them. She also has adnexal tenderness. So your adnexa are kind of, I put this image up to the right here. Your adnexa are kind of like the belly overlying your ovaries. So it'll be lower abdomen and on either side. So that's where your ovaries kind of lie. They're all folded up. They don't look like this in real life. But they're all folded up in there and you can have adnexal tenderness. So your ovaries are kind of tender. Again, that's not very specific, unlike the cervical motion tenderness. But it is good to note when we get to the diagnosis. Her discharge that you see on exam is yellow-green in color. Her cervix is nulliparous, which means that she's never been pregnant, just like you said, usually, or just like she said earlier. So the cervical os, which is kind of that teeny like hole next to the whole cervix, is it's small and round when you've never had kids. Once you've had kids before, it does shrink back to mostly its original size, but it kind of appears more like a slit. So that's how you can tell if a patient's had childbirth or had been quite pregnant before. Um, and also that the surrounding external genital skin is normal. So there is no like obvious source of infection or anything on the skin around it. So you'd think of, like genital warts or anything like that. There's nothing like that. That doesn't mean you can rule out necessarily herpes, but it does mean that it's not that kind of genital wart or you're not concerned about something external. Um, all right, so next we've gotten all this information, all this history, exam findings. What are some differentials that you're thinking of right now? It doesn't have to be super specific or anything, just or what are some common things that you're thinking about that could cause this lower abdominal pain in a 28-year-old for a couple weeks, the still achy pain. She's having cervical motion tenderness, slight fever, kind of a yellow-green discharge. What are we thinking about? Let's write some stuff in the chat. Some kind of STI, very good. What else are we thinking? What kind of STIs do you know about? Gonorrhea, very good. That's one of the most common ones you'll see. What else? STI or non-STI, what other kind of infections can happen in the genital area in a woman or someone with a uterus? Gonna wait for a couple more answers. UTI, very good. Yes, you don't want to rule that out. She's having burning with urination, so that could be a UTI. That might be something to check for. That's when we make differentials to rule stuff out and rule stuff back in. Cervical cancer, very good. The likelihood of this in a 28-year-old is not very high, but it is not impossible, especially if they have something like HIV or any other, if they're immunocompromised in other ways, which makes them more likely to get cancer. These are all very good ideas. Yeast infection, very good. You don't want to overthink it with yeast infection because that's very, very common in people with UTI. Crohn's disease or ulcerative colitis. Mm, I feel like those would present with more of a diffuse abdominal pain or left lower quadrant pain. Um, or honestly, it could present with any kind of pain. I would think in the abdominal area, you'd also maybe have blood in your stool, you'd have weight loss. Um, it's not really painting kind of an intestinal disease picture, but that's a very good guess, and it's amazing that you know about that. Anything else? Last minute call for things. Okay. So here are some differentials I thought of. So we have chlamydia and gonorrhea. Those are the two most common STIs you will encounter to the point that actually the testing is done together. It's a test of two in one. One other STI that's very important to not rule out is syphilis. Um, Another thing that I was thinking about is pelvic inflammatory disease, which we'll talk more about later. We'll actually talk about all of these later and how to differentiate between them. Trichomoniasis, which is a non STI infection, yeast infection that was mentioned earlier, bacterial vaginosis or BV, HPV, which is kind of what causes those genital warts or those sores around your mouth, vulvitis, vaginitis versus cervicitis. Cervicitis is actually what chlamydia and gonorrhea are, but we'll talk more about the where infections manifest along the genital tract, and then UTI, of course. You never want to miss your basics, and you never want to miss the cervical cancer, which I actually didn't list, so I did miss it. But you never want to miss those kinds of diagnoses, the basic ones and the very bad ones. So not everything is going to be a super rare thing. So definitely good to keep that in mind. Okay, so assessment and plan. I didn't really do much of an assessment because we kind of talked about it earlier, but the plan is we talked about UTI, we talked about STI. So how do we check for these things? So as I mentioned earlier, gonorrhea, chlamydia, the two most common STIs you will encounter in your practice. So they're actually tested together on this PCR test called the NAT. So you take a swab and you'll have it tested for both gonorrhea and chlamydia at the same time. Because gonorrhea, I believe, is a little more common than chlamydia, but there's actually a really high rate of co-infection of both at the same time. So they test for both. Then we have like a very scientific test called the whiff test, which is quite literally what it is. You take some KOH, so some potassium hydroxide, you put it on a little cervical swab that you've done, and you then just like very gently waft it towards your nose. And if it smelled very fishy, we're thinking bacterial vaginosis. That's very characteristic of that. So that's one thing you could do. We're also going to get a urine analysis, which is how you check for a UTI, and in that you'd see a positive leukocyte esterase, you'd see positive nitrates. These are kind of things released when you have an infection. You'd see a higher white blood count. You might see a high red blood cell count. Even if you don't see hematuria or like gross blood in the urine, you can still have microscopic blood in the urine that could be indicative of a UTI. That would definitely be something to do. The second person says dysuria, you absolutely want to check for a UTI because it can be kind of hard to differentiate in the region. What's one big thing we should do for this 28-year-old who has periods still? What is a big thing we should check for? Don't overthink it. She's 28 years old. She has periods. She's sexually active. Exactly. Thank you, Andrea. You want to get a pregnancy test. Any woman under 40, or sorry, under 45, or honestly under 50, who has not said that they're in menopause yet and is presenting with these kinds of symptoms needs to get a pregnancy test. Because even though the likelihood that this person is pregnant is not high, you want to make sure that she's not pregnant. Because if she's pregnant and has these infections, it's a very big deal and they need to be treated because you don't want to get the baby infected. And there's a lot of things that can happen there. And we'll talk about a couple of them. But the biggest the biggest thing right now is if she's pregnant, it's going to change treatment. Like if she's pregnant and she has chlamydia, we have to change the antibiotic we give her because some antibiotics don't work well during pregnancy for risk to the baby. So the CDC recommends the first line treatment for outpatient therapy. So if she has gonorrhea or chlamydia, you get doxycycline. Dosage, do not worry about that at this point, really. But you get doxycycline, that's to treat chlamydia, and the ceftriaxone, which it's one dose, and IM means intramuscular, so it's kind of like a shot. And you get one dose of ceftriaxone for gonorrhea, and that should take care of it for both. Um, if there's a concern for trichomonas, or there's been reasonable vaginal instrumentation, like let's say she just had a hysteroscopy, they just took a look in there or something, you'd be concerned about trichomonas, and so then you'd also get metronidazole. But we'll talk about that later in our non-STIs, kind of how to treat those. So yes, you want to get a urine analysis, you'd want to get a culture of that as well that kind of goes together. You'd want to get a NAT. You could do a wet mount. Not every place does this. I wouldn't do it in this specific case because you didn't have any concern for bacterial vaginosis, but you could do it. It doesn't cost you really anything to do it. And then you also want to get a pregnancy test. So those are the four things I would do. Um, so what this patient actually has, she's had this for a few weeks. She's having fever. Gonorrhea and chlamydia don't always cause fever because they're very localized infections. But what this woman has is pelvic inflammatory disease. It's not very commonly heard of. Has anyone heard of it? Basically, it's when you have gonorrhea, chlamydia, or any other infection that travels up the cervix. So gonorrhea, chlamydia kind of colonize here. They colonize the vaginal canal and the cervix. And that's why you can have these kinds of symptoms. But if it moves up further into the uterus and even into the fallopian tubes, into the ovary, that is when you get pelvic inflammatory disease, because the whole area is inflamed. And then you'll get this kind of adnexal tenderness. You'll get the cervical motion tenderness, which is when they kind of jump out of their skin when you perform a pelvic exam. And they have low-grade fevers because it's become systemic at this point. It's kind of like when a UTI progresses up to the kidneys if it's untreated, and becomes pyelonephritis, and you can get really sick from that. It's the same thing here. If you don't treat your chlamydia or your gonorrhea, because a lot of times they present asymptomatic and patients don't know that they have it, it can progress up here. And this is a very big deal for a 28-year-old woman because what if she wants to get pregnant? This is one of the leading causes of acquired infertility, PID. So let's talk about it. Sorry, this image, if it makes you feel a little squeamish. Let's talk about it. How does this how does pelvic inflammatory disease cause infertility? So look at all these little adhesions. These are called adhesions. They're scar tissue that is built up. So none of this should be here. Maybe only one of these, this is a ligament here, should be there, and the one back here should be here. But all of this should not be there. Let me move this away so you can see. In like the image on the right, which is a little less literal, you can see all of these adhesions here, kind of an inflamed uterus, or sorry, ovary that's way bigger than it should be. These are all adhesions. This is kind of what happens if people who have frequent abdominal procedures, they develop adhesions because of just the surgical site incisions, and then they have like bowel obstructions because of it. This is the same mechanism here. So if you keep having inflammation, it's all going to scar over and become fibrotic in the ovary, in the fallopian tubes, in the uterus. And then how is a sperm supposed to get all the way up to the fallopian tube and fertilize an egg if the egg can't get out or if the sperm can't make its way up because of all of the adhesions? So this is actually a very big cause of infertility. And then the patient, if they do want to get pregnant and hold a baby, really only has the option of IVF because IVF bypasses the ovary and fallopian tube entirely and fertilizes externally and then puts into the uterus if the uterus doesn't have adhesions. You can also do an ablation, which kind of like gets rid of all of the uh, adhesions in the uterus itself, but you can't really do that with the ovary and fallopian tube. And also those adhesions have a high likelihood of coming back because that's another form of trauma to the uterus is doing an ablation itself. So it's a very big cause of infertility, and that's why the CDC recommends annual screening for gonorrhea and chlamydia for sexually active teenagers and women under 25. So if you're under 25 and you're a woman, you're considered high risk for sexual behavior. They're less likely to use condoms, other forms of contraception, more likely to have a higher number of sexual partners, use substances while having sex, those kinds of things. And those all put you at a higher risk of getting chlamydia and gonorrhea. And they get asymptomatic, so they have no idea they have an infection. They're not tested once a year once they see their gynecologist, and then things like this can happen. So it's very important that if you treat patients under the age of 25 and they're sexually active, that you ask them at least if they would like to get a test and make clear to them that they could have no symptoms and still have this infection and that it could lead to infertility. So it's important to discuss. Other risk factors are, besides the ones we talked about, like risky sexual behavior is having recent IUD insertion. So any kind of trauma to the uterus or the area can really um, cause pelvic inflammatory disease. It's a very, very low risk from IUD insertion, but it is still there. Or any kind of history of STIs can do this, like we just talked about, history of smoking, which makes you more likely to clot and also more likely to not heal and from infection can do that, and other history of other gyne procedures like hysteroscopies, things like that. So let's talk a little bit more about other gynecological infections. We'll do a slide on non-sexually transmitted infections and one on STIs itself. So this is the cervix here. Um, it can appear like this, slit-like if they've had a baby. It can also appear like a dot if they haven't. I wouldn't count it as an indicator of either one at this point. But there are three kinds of main non-STIs that we want to think about that kind of colonize the same area. So we want to think about bacterial vaginosis. So people often refer to it as BV. And this is kind of like a gray or milky discharge. I would not diagnose based on discharge alone. Obviously, these can all present as the other. But one thing that's very, very um, specific for BV is a fishy odor. So it's a positive amine test, and that's what I was talking about with the whiff test, where you put potassium hydroxide and kind of whiff it towards yourself. And if it smells very fishy, or if you're doing the exam and it smells very fishy, you should be concerned for BV. Um, They'll also, when you test for the pH, so when you get the whiff test done, you're also testing like on like a little Q-tip, you're testing for the pH and like the presence of nitrates, things like that. You can do that on like these little dipstick things, and they will have an elevated pH of over 4.5. So a normal vaginal pH, does anybody know what that should be? We know it's acidic, so I'll give you a clue there. Okay. Well, a normal vaginal pH should be around 4. Yes, exactly. Gold star. It should be around 4. So it's very acidic when you remember that neutral is 7. And this is just really why it keeps it clean. This is why we encourage women or people with uteri and vaginas to not douche the area, not put soap in the area, because they're very acidic to keep themselves clean. So they don't need anything extra in there to mess up the pH, because if you mess up the pH, you could get one of these non-STI infections. And then they'll have Kluskels on microscopy. But that's not very important for you guys to know right now. The other thing you can have that's not well known about is trichomonas. They'll kind of have this yellow-green frothy discharge. And one other thing that they can have is strawberry cervix, which are kind of these punctate little hemorrhages. So they're called strawberry cervix. And you'll have foul-smelling discharge. But again, foul-smelling discharge is not a specific finding. And it's a protozoal infection, so you'll kind of get this here. And it's treated with metronidazole. BV is treated with metronidazole or clindamycin. Mostly metronidazole because it's less associated with the risk for C. diff like clindamycin is. But those are kind of what those two are treated for. And then a yeast infection, which is very common. It'll have this thick curd-like cottage cheese discharge. You'll have a lot of pruritus, which is the medical term for itching, associated with this. And then these are actually often you'll get them plated and looked under microscopy, and you'll see these pseudohyphae, which are kind of these buds of yeast coming out. And of course, these will all have inflammation, except for BV, which is pretty benign. But you'll have inflammation, so the area will be erythematous, it'll hurt, that kind of thing, the itchiness that we talked about. But this is more, yeast infection is more likely to have a normal pH, but is also associated with more acidic pH than it should be, or sorry, it's associated with a more basic pH. Um, and the treatment for this is fluconazole, which is known by its brand name diflucan. And instead of metronidazole or clindamycin, which is like an antibiotic course of about a week, you'll actually just give a one shot of diflucan to the patient. Um, it has some pretty decent drug interactions, especially if the patient's on SSRIs. But there could be some cardiac abnormalities, but in most patients, this is really not a concern at all, and you can give them at the same time. There's no issue because it's just a one-time dose. And then the other thing I wanted to talk about on this slide is vulvitis, vaginitis, cervicitis, and UTI. So these are all infections in a very similar area, but are kind of different. So UTI, we all know, is in the urinary tract. So we're talking about a bladder infection or a urethral infection, which is more common in men, but bladder infection overall is a UTI. What what cervicitis is your gonorrhea, your chlamydia, these kinds of infections that are near your cervix. But then you also have vulvitis and vaginitis. And what's that? So your vulva is kind of this area around here, and your vagina is like the very inside of the canal. So it's inside versus your vulva is outside the genital area. And so if you're having like a vulvitis or vaginitis, that's not really any of these things most likely. What you're concerned about is not STI or any of these three. You're concerned more about is the patient, then this is when you become more of an investigator, which is the fun part of medicine. Did you start any new laundry detergents recently? Are you using cotton underwear? Are you using new underwear? Um, are you having sex with somebody new? Like any of these things, because what vulvitis and vaginitis are more topical dermatitis. It's like it's a very specific, it's specific more for irritation of the skin rather than an actual infection of something. But this irritation of the skin, if you get a breakdown of this barrier, you could make it more likely to have these other STIs because the skin barrier has been broken down. So that's just a kind of a way to think about it. If it's an outside or directly inside in the vagina, kind of discomfort or redness, things like that, you want to think about other factors besides just infection. Whereas if it's further along, like a cervicitis, you definitely want to think more of an STI type infection instead of a more dermatitis related infection. Okay, before I move on, because that was a lot of information that I threw at you, questions, comments, anything like that, because we'll talk about STIs. I'll give you 20 seconds, so. Okay. If you have questions at any point or any kind of comments about anything related to it, I will do my best to answer it. Definitely put it in the chat. That's why I'm leaving it up on the screen. This is more for you guys, but it is a good review for me, first step. So helps both of us. All right. So STIs, this was the first thing that we all thought of when this patient presented. And I mean, it is ended up being what she had. She had positive gonorrhea, chlamydia. That's how she got pelvic inflammatory disease. Um, so let's talk about syphilis versus gonorrhea, chlamydia. Syphilis is much more rare and it also has a lot more complications. So let's talk about them. So syphilis, the primary stage is you'll get a painless lump or a sore called a, I've never actually said it out loud, so don't hold me to the pronunciation, a chancre. And you'll have it, it'll be like a single spot, like the image on the right where you see like a singular spot. That's what is more characteristic of it that resolves on its own within 3 to 6 weeks. And the very important part about it is that it's painless. If it's painful, you have to think about a couple other things, called chancroid, which is like a Haemophilus dicrei infection. But if it's syphilis, it is a single painless sore that resolves on its own, and that's primary stage. The secondary stage is if the patient doesn't realize they've had this sore, or maybe they didn't even have a sore, they start getting a rash on the palms and soles of their feet. They get a flu-like symptoms, like they'll get a fever, they'll get swollen lymph nodes, they'll have a little bit of weight loss because it's spread to the body at this point. And obviously, nobody who comes with upper respiratory infections is going to think, oh, I've had more sexual activity lately. I might have had a partner who had syphilis. Nobody's going to think about that. So that's just something to keep in mind when you're thinking about upper respiratory infections, that it might be something like syphilis, not necessarily like a common like like cold or flu, things like that. And then latent infection can also happen where it goes away, where it's still present in the body and it's kind of just staying dormant for now. That's very common with syphilis as well. And then the tertiary stage is the one you never want to reach. And this is years and years of syphilis, but it can really occur at any time. Um, you will get like neuro symptoms. So we're talking brain damage, blindness, altered mentation, meningitis, paralysis. This was actually a huge issue. If you guys have heard of the Tuskegee syphilis studies, which were done on Black men, I believe in the 1900s. I don't remember what decade, but it was a huge concern for ethics because some men were treated versus some men were not treated, even though the study coordinators knew that they all had syphilis. And so those men actually did develop tertiary syphilis and died from meningitis, and had very, very low quality of life later due to brain damage, blindness, and paralysis. Was all preventable because the treatment is just good old penicillin. And you use long-acting penicillin, which is called penicillin benzathine or penicillin G. And you do like a shot of it, and that should take care of the syphilis. If you have kind of like more disseminated syphilis, you might need a shot once a week, but it is really just penicillin that gets the job done, which is why those cases were a lot more tragic. And if it's untreated, it's disseminated, like we kind of talked about here. So that's why syphilis is really important and why the complications are really important to consider. And what about herpes? So herpes are this image on the bottom. These are clusters of vesicles on an erythematous or red base that you can kind of see here. So this is genital herpes. You can also get herpes, which are cold sores around the mouth. Those are very similar. And because all herpes viruses are active, they are active in the dorsal root ganglion, which is part of your spinal cord. They never go away. They're very closely related to chickenpox, varicella, because stay in the dorsal root ganglion and they can reactivate at any time, especially when the patient is under mental or physical stress. They can reactivate. So you never get rid of herpes, unfortunately. So you can keep having recurrences of these genital ones, the cold sores, anything like that. So you kind of treat with an antiviral, which is called acyclovir. Actually, when I worked on family medicine, I worked with the doc who treated a local university's wrestlers, and a lot of them are on low doses of acyclovir as a maintenance because because of all of the fighting they do on the mat. There's a lot of skin infections that are shared with them and their competitors, and even their teammates. So they actually have a higher risk of herpes and other facial issues or facial infections, skin infections, just because of the nature of the sport. So a lot of them are on low dose acyclovir because they'll get herpes breakouts on their face along a specific dermatome, which is like a specific distribution of skin along your body. And those are painful, and also it keeps you off the mat. So those have to be treated. So that's an interesting patient population you don't really think about. And then one thing is the HPV vaccine and screening that I wanted to touch on. So HPV can cause cervical cancer. It's the biggest cause of cervical cancer. I believe it's about 90% of cases in women. And that stands for human papillomavirus. And so we give the vaccine, especially to women, but we also give it to young men as well. So we start asking patients' parents and the patients themselves if they would like to get it around like 10 to 12 years of age, I believe, 11 to 12. We want to get it before they're sexually active, which as a parent, you can never guarantee that when that will happen with your child. So that's why we kind of ask around the 11 to 12-year-old, if they would like to get it then. We give it to boys because they might have sex with women, and we don't want those women to eventually get cervical cancer when it's very preventable. So that's kind of why we do that vaccine in men as well as women. And then screening for HPV is done by a pap smear, which you do at 21, regardless of what age you became sexually active. And that's done with the pap smear. So they just take a little like long Q-tip essentially and just like kind of scrape along very slightly the cervix, and then they send that off to testing. And you do that every 3 years in patients with uteri. And in your 20s, it used to be done every year, but they realized that most women this age clear the infection and doesn't actually worry about becoming anything more long-standing that turns into cervical cancer. So it's done now every 3 years. And then once you hit 30, you do co-testing. So you do like a pap smear plus HPV DNA testing together. And that can be done every 5 years until you're 75. And then they kind of stop because after that, it's like a length of life issue. So 21 to 75 women or people with vaginas are tested for cervical cancer through these HPV screenings. And that's really important because it's very, very preventable. It's incredibly effective in preventing cervical cancer or treating it once you have it, which is a whole nother discussion on its own. And it's very interesting, all of the things that we can do to treat cervical cancer and still keep women being able to be pregnant and things like that. So it's really incredible how far we've come. Okay, we talked about pelvic inflammatory disease. What are some other complications? This is the last slide, by the way. If you're losing interest, just hold on a little longer. But last slide, what are other complications of syphilis and these other STIs and things like that? So the main thing is that you've impaired your barriers. Your mucosal barriers are very important. Your vagina and your cervix are all mucosal barriers. They clean themselves, they self-lubricate, all of these things. But if you've had a long-standing infection, you know, that barrier is compromised. And so you have an increased risk of other STIs. Or if you just had like a vulvitis or vaginitis, you have increased risk of STI, HIV, those kinds of things if you have already an impaired barrier, because there's an easier way for that infection to now get in. So some specific things that I was thinking about. So for herpes, like we talked about, is cervical cancer, and it comes from HPV type 16 and 18. But these two HPV types actually lead to a lot of other types of cancers. Like you could have pharyngeal cancer, which is like throat cancer. You can get cancer of your vulva, your vagina, your penis, your anus, like the whole area down there. But those things I feel like are more things you'd think about other than cervical cancer. But the pharyngeal or throat cancers, actually, I believe like 30% of them are caused by HPV, type 16 and 18. HPV types like I believe 9 and 10 or 6 and 7 are the ones that are non-cancer related, but that can cause the warts. So not every HPV is a worry for cervical cancer, but it is a worry that they're not using adequate protection and should think about that so they don't get the more serious strains of HPV. Oh, sorry. That I meant for herpes to say HPV. Those are not the same thing. Chlamydia, one thing that it can cause besides pelvic inflammatory disease is a perihepatitis. So if you look at the image at the top, you see these kinds of adhesions on the liver capsule. It's not in the liver itself, so it's not hepatitis, but it's around it. So it's called perihepatitis, and it's pretty painful for the patient. You have to be put on antibiotics. Really, anything that like invades the abdominal cavity here can cause perihepatitis, but it's very specifically associated with chlamydia for some reason. It'll get into the ovary, cause like infection, like inflammation of the ovary, and then the ovary kind of transmits that to the liver is how that works. Gonorrhea, what's specific about that is it can become disseminated just kind of like syphilis can, and it'll cause this kind of achy joint pains, and it'll cause this dermatitis. You'll get these specific types of rashes, you'll get arthritis, which is just joint pain, tenosynovitis, which is pain of the joints and the joints capsules. So very, it kind of presents kind of the same as arthritis anyway. And they'll be asymmetrical, which means that you're not going to get it in both knees. You'll get it in one knee and an elbow somewhere and things like that. So it kind of spreads that way. And you treat it the same way you treat gonorrhea normally with antibiotics. And then with syphilis, we kind of talked about the neurosyphilis, but it can cause a lot of other things too. You can get cardiovascular syphilis, which kind of goes into your aorta, so your main blood vessel carrying blood from your heart to your body. And if you get inflammation of that, it's obviously not very great at all. It's very serious. It can cause valve disease as well. For gummatous syphilis, those are things more affecting like mucosal surfaces. You'll get like some soft tumor-like lesions that get into your skin, your bones, and your organs. And then you can also have congenital syphilis, which is what I'm showing in these other two pictures here. So what's kind of interesting is babies who are born with syphilis, you will notice that they're kind of like, they have the snuffles. So they'll have like this kind of rhinitis where they have like a clear nasal discharge and things like that. So if you see that in a baby, like a newborn baby, I would be a little concerned about syphilis. But in today's day and age, that's very rare because moms are tested for this at multiple stages in multiple trimesters because it's a big deal. They can get these kind of skin and disorders of like vesicle and bullae. There's issues with their bone formation. They can have sensory neural deafness, which is actually a very common association with a lot of different infections of the placenta that you can have, but syphilis is one of those causes. You can have eye problems with seeing because of interstitial keratinitis in your corneas and your eyes. And then one other thing that I think is interesting is you have this finding called Hutchinson teeth, which doesn't really appear until you're a few years, the patient is a few years old. But these are kind of like what the teeth look like, and they're more prone to decay and infection. And you have to go see a dentist, and they fill all of these in, but it just makes it harder for them to chew, and it's obviously not a pretty sight. And it's, but again, very uncommon these days to see this in the US. Okay, I have thrown a lot of information at you. So, what questions do you have? I covered a little bit of everything, kind of tried to keep it short and sweet, but of course, that was a lot of information. So, what kind of questions and thoughts and concerns are we having? Any information about anything else I can tell you more about? I find all of this stuff very interesting, even though I don't want to go into the field. So, happy to hear any kind of questions. Okay, I'm gonna give you guys a little more chance to um, think of questions if you have any. There's a lot of good ones you can think about this, and it is kind of like difficult to kind of put all synthesize all of this together. So I'll give you another minute while I give you some more information. But future virtual shadowing topics that you can come to besides mine, which is definitely a very interesting one, is hypoxic ischemic encephalopathy, which is something babies can be born with if they have any kind of issue during childbirth where they lose oxygen. So that's kind of what this presentation is about. There'll be some surgical case studies, some information about immunotherapy and cancer treatment, which is a huge burgeoning field here, and then xenotransplantation. There's also some links here about reviewing some interview questions if you're applying this year. I saw some of you were saying that, and a little bit of information about the pre-med app, which Motivate MD does as well. And then there is going to be a takeover on our Instagram stories tomorrow that Motivate MD wanted to share.
Taking over the Instagram account this Wednesday on the 16th. I am a first-year radiology resident at Duke from South Florida originally. I went to med school at NYU in New York. And now I've been in Durham for about 2 years. I'm thinking about going into either body radiology or neuroradiology, but I have a whole lot of training ahead of me and I haven't really decided yet.
So basically his presentation, or not presentation, I guess, will be more tomorrow. It'll be on his stories on Motivate MD on Instagram, and you can kind of see what the day in the life of a radiology resident is like. So if you're interested in the field, that would be a way to do it. Okay, Abigail, I saw your question. So the symptoms of cardiovascular syphilis, that is a great question. We talked about aortas being affected and valve disease. So you would think about I had a word in my head and I just lost it. So you think about worrying about aneurysms. So you'd get like aortic aneurysms where it gets really wide, and symptoms of valve disease as well. And those could be like syncope, so passing out with exertion. So you're working out and you suddenly pass out because you're trying to push too much blood through a valve that's not really working well, and you're not getting enough blood across. So you pass out. You'll hear murmurs if it's a valve disorder. Be more fatigued, very non-specific finding. Literally could be a billion things, but that's one thing you can see as well. With aortic disease, I wonder if I'm not really sure specifically if there's anything that's an indicator for that other than getting an echo and literally seeing how wide it is, or getting in its chest x-ray and being able to see the aneurysm on it. But presentations for aortic disease can be quite varied. So I would stick to the being able to listen for murmurs and knowing about the syncope with exertion, having some kind of chest pain. Those kinds of things can all happen. What other questions?
Hey everybody, I'm Quinn.
There's a 10-question quiz. If you guys want to have some certificate of completion for this, if you get 80%, you'll be emailed that certificate. And there's a Google folder that has other resources for you. If you want to reach out with additional questions or anything, feel absolutely free to. I'm just going to put my email in the chat real quick. If you have other questions, I really do not mind answering them. And I'm happy to talk more. All right. Thank you guys all for joining. And I hope you all have a good night.